I'm very happy to ask Vedran Stefanovic to share his presentation with me, and then he's going to talk about the ventriculomegaly. This is another hot topic. Welcome, Vedran.
Thank you very much for the invitation to present this. And I say good morning and good evening, as I see that there are so many people around the world here. I hear that my good friend Ana Bianchi from Uruguay is here, and it's the middle of the night. And I see some of my Croatian friends and all other friends and colleagues. And it's very nice, and I thank you very much for the sacrificing that you sacrifice your time in this, at least in Helsinki. It's very beautiful weather, but it's nice to see you. It's a little bit sad that we are not just face to face, and I'm just accompanied by this beautiful glass of mango juice, and I hope that I will make presentation that every one of you will benefit. You hear me?
Yes, very well.
Thank you. So just a short idea of me. I'm a specialist for fetal medicine, and I work at Helsinki University Hospital. And Finland is a quite large country. From south to north, it's 1,400 kilometers. But we have only 5 million people here and 5 university hospitals. And my center is a referral center for the whole Finland for the serious cases, and also most of the neonatal surgery is done only in Helsinki, because we are trying to reduce the costs and of course improve the quality. Concerning the fetal medicine, we have by law, we guarantee each woman, regardless of the status, whether she is a resident or a refugee that came yesterday to Finland, they have a right for 2 screening ultrasounds. In the capital area, the uptake is almost 100%, and in some other areas, it's a little bit lower. And we also offer cell-free fetal DNA only for risk patients in the public sector, but it's available in private hospitals and clinics around Finland. And I'm proud to live and to work in the country which is top 5 in the world concerning the very low maternal mortality, stillbirth rate, and neonatal mortality. So today I'm going to talk about mild ventriculomegaly, which actually might not be very frequent finding in the background population, but definitely it is much more frequent in the tertiary referral centers. I'm going to talk about the definition, which is actually quite easy, about the incidence, about the diagnosis, which is also very easy, but then a little bit more complicated, and disputing further fetal evaluation and counseling, and also pregnancy follow-up and the outcome. What maybe has not came during the previous sessions, we now have, of course, to counsel and investigate the patients according to our best knowledge and according to the evidence-based medicine. But the whole thing is definitely dependent on the degree of the sonographer experience, because I guess among us today, there are also some so-called general obstetricians and some people that are just in the beginning of their career in the fetal medicine. It is depending on gestational age presentation, availability of screening and diagnostic tests, cultural and religious features. Just to make your little bit information about how we do in Finland. In Helsinki area, those, for instance, with the 21 trisomies are terminated in 80% of the cases. So it means that 20% of all Down syndromes, which are still eligible for termination of pregnancy, they want to continue pregnancy. The far north you go in Finland, the less terminations are done. Also, we, like many other countries, we have a lot of refugees from poor countries with a very poor education, and sometimes it is very, very difficult to make a counseling within 40 minutes or 45 minutes with to the mothers that don't have any idea what is, for instance, chromosomes. Also, there are legal issues. In Finland, you can terminate pregnancy up to 22 weeks for social reason. Just if you don't want that pregnancy, even if the fetus is healthy, you don't have to explain anyone why do you want to do that. But if the fetus has anomaly, you can do that up to 24 weeks. And now this goes This is very important when we are counseling patients with a ventriculomegaly, because then we are a little bit in shortage of time. And as I said already, education level of patient is very important. So what is the definition? This is well known to all of you. The definition of ventriculomegaly is dilatation of the posterior horn of fetal lateral ventricles, and it is usually observed at the time of the assessment of fetal anatomy between 20 and 22 gestational weeks. But also it can be observed in the first trimester, and I have just one slide at the end of my presentation about the first trimester ventriculomegaly. It may be isolated or it may be associated with other anomalies. It can be unilateral, bilateral, symmetric or asymmetric. And some people use a term borderline, and it is about 10 millimeters. What I'm going to be concentrated on today is mild ventriculomegaly, so the enlargement from 10 to 12 millimeters, and I will skip the moderate and severe, which is more than 15 millimeters. Also, what is very important, we are talking about isolated. What actually isolated means? Isolated ventriculomegaly, in my opinion, could be diagnosed only postnatally, when you don't have anything else to see. So what we are talking about during the pregnancy, it is apparently isolated ventriculomegaly, and unless we rule out associated genetic diseases, infections, and postnatal findings, we can't talk about the isolated ventriculomegaly. Although often incidental and benign, as I told you, it may be associated with the infections, genetical, structural anomalies, and neurocognitive disorders, and the outcome range from normal to severe impairment. There is some discussion about how people define severe ventriculomegaly compared to hydrocephalus. In hydrocephalus, the mechanism is always obstruction. In mild ventriculomegaly, it is very, very rare. And in the left side, I would say that this is hydrocephalus, and the right slide would be ventriculomegaly. It is very important how to measure. We have to bear in mind that the fetus is growing, and all the structures are bigger in advanced gestational age, but atrial diameter remains very stable between 15 and 36 weeks. Median width of the posterior horn is about 5.4 to 7.6 millimeters, and the width of 10 millimeters represents 2.5 to 4 standard deviation above the mean. We have to image the fetal head in transversal axial scan, and the midline structure should be visible. And I think this you are very familiar with this. So we have to see cavum septum pellucidum, we have to see anterior horns, we have to see posterior horns, and then we have to put the calipers from here to here, and then to see what is the width and make our diagnosis. How often this happens? The incidence of mild ventriculomegaly is about 1%, unilateral in half of the cases. It is more common in male fetuses, but it doesn't give many information for us, because there are no data indicating that prognosis for this finding differs by fetal sex. We have heard yesterday, and we have heard also today, that ventriculomegaly, not isolated, but ventriculomegaly can be associated with a different structural abnormalities, not only in the other parts of the body, but also in the central nervous system, like holoprosencephaly, porencephaly, schizencephaly, and tumorous lesions. We have heard a great presentation about the corpus callosum agenesis, and also in the aqueductal stenosis, but if such, it is usually primary or due to the infections. In this picture, one might think that this is ventriculomegaly with 13 millimeters, but actually this is a large choroid plexus that may mimic ventriculomegaly. So this is the area, and what we can offer, or what we should offer to our patients. We have to know that, taking into consideration all degrees of ventriculomegaly, approximately 5% of fetuses with apparently isolated ventriculomegaly will have abnormal karyotype, but however, most of those fetuses who are abnormal would have a trisomy 21. but another 4 to 10% will have abnormal finding in chromosomal microarray. And I would say that if even in the case of the normal first trimester screening, and now in the second screening when the ventriculomegaly has been revealed, I would not offer as a primary investigation fetal cell-free fetal DNA, since substantial proportion of chromosomal abnormalities would be missed by this approach. But it is just how you counsel and what the patient is ready to take. If woman declines a priori amniocentesis, we can take the risk of trisomy 21 that she had in the first trimester, and we have to adjust it at least by using conversion factor 3.5 for the presence of ventriculomegaly. But I don't know how far we will go with that, because definitely that would be the screening. We can adjust her risk, but we can't say you have a baby or you don't have a baby with a 21 trisomy. So on the basis of fresh data, I would say that offering the chromosomal microarray will give us 4 to 9.5% more chromosomal abnormalities that are associated with fetal ventriculomegaly. But it is not always easy. You can have increased, of course, incidence of those anomalies that we don't know what they mean, so variant of unknown significance. And also, if you use a single nucleotide SNP arrays, it can identify consanguinity and non-paternity, which is not very comfortable. So comprehensive pre-test and post-test genetic counseling should be offered by professional geneticists or fetal medicine specialists that are very comfortable with genetics in order to counsel patients properly. We have heard a great presentation about the infections, but just few things specific to ventriculomegaly I would like to point out. So approximately 5% of cases with mild to moderate ventriculomegaly are reported to be resulted from congenital infections, and most of them if there are cytomegalovirus and toxoplasmosis. Some people say, well, you should screen or make a diagnosis for Zika virus, but there are very sporadic cases, and also we actually do not know what is the prevalence of the ventriculomegaly in the cases with the Zika virus infection. A few words about the pathogenesis of ventriculomegaly associated with infections. It may be due to adjacent cerebral atrophy, aqueductal stenosis, communicated countercephalus, but usually cases of ventriculomegaly which are associated with infections, they also appear having other sonography features, as we heard in a very nice previous lecture. Tests for CMV and toxoplasmosis are recommended when ventriculomegaly is detected regardless of known exposure symptoms. This is what the Society for Maternal and Fetal Medicine recommends. For women with history of travel to any Zika endemic area, it is also recommended, but as I told you, what we don't know, it is unknown the diagnostic accuracy of the serum or amniotic fluid PCR for Zika virus, and also the prevalence of ventriculomegaly in this kind of virus infection. I think this is also very important. I go a little bit into more details than my colleague previously said. So always amniotic fluid PCR is preferred over maternal serology. Positive predictive value approaches almost 100% in CMV and toxoplasmosis infection, but if amniocentesis with PCR is performed in less than 21 weeks of pregnancy, then it has only 45 to 80% sensitivity for CMV. PCR performed more than 21 weeks or 6 weeks for maternal primary infections has sensitivity and specificity close to 100%. So this is very important when we are making a decision and counseling the patient. For toxoplasmosis, PCR from amniotic fluid has sensitivity of about 46% and negative predictive value of 87%. So I try to summarize in this table what are the advantages and what are the advantages of invasive diagnostics and non-invasive diagnostics, which actually already you heard. The main difference is, of course, miscarriage risk in amniocentesis. In our hospital, it's about 0.2%, and non-invasive, of course, does not represent any miscarriage risk. But all these things that I have been already discussing are summarized in this table. What is the role of ultrasonography? As we are obstetricians and fetal medicine specialists, it's a crucial tool in our hands, and the incidence of additional CNS and non-CNS abnormalities in fetuses with mild ventriculomegaly is 10 to 76%, but 50% in most of the studies, and definitely it is dependent of who is performing the initial ultrasound. Third level ultrasound should be performed with someone who is called himself or herself as at least a small expert, with the complete evaluation of intracranial anatomy, also fetal card, echo, biometry, and signs of fetal infection. The role of MRI, whether do you send or you don't send, there is no any consensus if magnetic resonance should be the must for evaluation of fetal mild ventriculomegaly, and the scientific evidence is grade 2B. The problem is, for instance, in Finland, as I told you, we have a 24 weeks as a cut-off for termination of pregnancy. And if women is referred for in 21st or 22nd week for a mild ventriculomegaly, there is really only less than 2 weeks that you have to do everything if she wants to do a termination according to the set of findings. Additional abnormalities can be found in 5 to 50% of the cases, again, dependent of the quality of the initial ultrasound, but most important and important clinical findings are to be revealed in about 1 to 14% of the cases in isolated, apparently and initially isolated ventriculomegaly. So I think that if you are available to provide MRI, it should be offered to all the patients with the, what is this? In all patients with ventriculomegaly. I can't go further, yes. How to follow up this pregnancy? Follow-up should be individual, like in every pregnancy, and the multidisciplinary approach might be indicated. For isolated mild ventriculomegaly, I would say that 4 to 6 weeks interval may be appropriate, because we see in about 15% progressive dilatation. Antepartum routine fetal testing is not likely to be beneficial in any case, because these anomalies are usually not associated with placental insufficiency, and timing and the mode of delivery should be based only on standard obstetrical indications. Fetuses with ventricular arterial diameter of 10 to 12 millimeters are found to have very good examination in more than 90 up to 95% of the cases, but mild ventriculomegaly is likely to present a normal variant if no other abnormalities are noted, or if aneuploidy screening or diagnostic tests are normal. However, what I said in my second slide, what we say, this is isolated ventriculomegaly, we have the chance or possibility in 7 to 10% of the cases with during pregnancy apparently isolated mild ventriculomegaly to change the diagnosis that the baby still has some problem. So normal variation cannot be made with certainty until after birth. There are 2 big studies from Pagani and Bar yourself. One is Italian and one is Israeli study that they said again that in isolated mild ventriculomegaly, the rate of neurodevelopmental delay is very low. And another, this Bar Yosef study, also it was done by MRI, has revealed that the outcome is very good in isolated. And also what is very important, they said that it is the same regardless of the severity of asymmetry of the ventriculomegaly. So just the last slide about the, if you find, and what is actually definition of first trimester fetal ventriculomegaly. There is not so much literature on this, and what I could find, it is the only publication from 2016, and very small case series, when in the pictures ABC, you see the normal fetal head in the first trimester, and in this DEF, you would see what I would also find suspected, that this is a little bit enlarged, or actually this plexus choroideus does not appear as a typical butterfly sign. So what they found in the case series of 17 cases, so they found that in 30% of cases it was isolated. They have found that in 70% of the cases it was associated with further sonographic anomalies and very severe ones. And they have found 30% of the cases on aneuploidy, and in 52% of the cases it was associated with nuchal translucency. So this should not actually be missed. But the problem is that this is a very small retrospective study, and the diagnosis was more kind of subjective than any kind of measurements. And also the problem is that the long-term follow-up was not arranged. So in conclusion, when you see what looks to you abnormal, you have to do even more detailed anatomy, and invasive procedure and further evaluation should be offered if this ventriculomegaly is observed in the first trimester. I thank you very much, and I send you very nice regards for beautiful Finland with a beautiful day. So in the summary, as I told you, this is quite rare, but in general population, but you encounter it very often if you work in the third level center. Meticulous diagnostic flow chart, including the ultrasound, magnetic resonance, genetic tests, and ruling out of the infection is essential. And one thing that maybe one could ask is routine screening for alloimmune thrombocytopenia indicated in this anomaly. Actually, it is not if this is isolated. In absence of any infection, fetuses are in most cases found to be normal, and they have a normal neurological outcome, and we don't have to rush with their delivery. Antenatal care should be actually individualized, but in most of the cases, normal pregnancy surveillance is completely enough. Thank you very much.